Good evening to everyone. I am Cosimo Pieri, and I am from the board of Europa Uomo and also part of the Europa Uomo Italy Association. Early diagnosis and active surveillance, how to balance under-over treatment. With this third webinar, we want to continue to give a basic introduction of active surveillance, and especially today's focusing on this argument of under-over treatment. So the idea today is just to give an overview of the benefit of active surveillance, and also give an overview of how it is useful to apply the multidisciplinary approach in general to reduce overdiagnosis, which may lead to the use of active surveillance in all ways that are possible. Today we have organized with two testimonials, and then we will have Professor Chris Bangma, giving us an overview of the arguments which are related to what I was saying. Now, the first testimonial is Train Tormason from Iceland, which is the first testimonial. And Train is the chairman of the board of the local Iceland Prostate Cancer Association, and is also co-founder of the first independent active surveillance support group. So Train, we have already spoken before. We see you fine, even if you are near Vulcano. So we hope you won't be covered by lava today. Okay.
Hopefully not.
No. Here we have thought about a few questions. Let's say, obviously, you can give your overview more or less. What is important to understand is what was your experience, in a certain sense, the importance of a second opinion, and if you had to cope with anxiety during the journey. So more or less, these are some questions, but you certainly will give us a good overview. So I leave you to go on, Train.
Oh, thank you. Cosimo, this is a great honor to have the opportunity to address this webinar. You gave me 3 questions to answer. How was my experience of active surveillance, and the importance of second opinion, and how to cope with anxiety during the journey. I have decided to write my presentation as we are restricted on time. I hope you understand my English with the Viking accent, because as you probably know, Icelandic, we speak the same way as the Vikings did 1100 years ago. Well, the first question, how was my experience of active surveillance? Active surveillance has made a huge impact on my life. Sorry, my phone is. Active surveillance has had a huge impact on my life. If I had not chosen active surveillance in 2005, my life would most likely have been different, and I would have missed considerable quality of life. My active surveillance is a little bit special. I started PSA testing over 20 years ago in the year 2000, when I was 56 years old. No reason for starting. I just read in a paper that PSA blood test could be of importance. My PSA value proved to be 5 when I started. Once a year, I had a PSA test, and the value increased every year. The doctor didn't tell me that PSA level above 4 was a sign to be watched. I did not seek any information about prostate cancer matters. I just trusted what the doctor told me after each PSA test every year, and that I was in a good shape. After a PSA test in January 2005, the doctor called me. It so happened that I was in Norway at that time. I asked if I was not okay as usual, but he said no. I would need to have further tests. We should discuss the issues when I return to Iceland. He didn't want to give me more information at that time. I have seldom felt as badly as during the rest of the days in Norway. I became very anxious and depressed. What was this about? Did I have cancer? And was my death around the corner? I didn't know anything about the disease. When I returned to Iceland, I met with a doctor who told me that my PSA value had reached 10 and I needed to have a biopsy. The result was that I was diagnosed with prostate cancer with Gleason score 6, 3 plus 3. Second opinion showed the Gleason score 7, 3 plus 4. I asked the doctor what to do. I booked you for a surgery next month, was the reply. At that time, almost all men diagnosed with prostate cancer went into treatment. I met the doctor again and had a number of questions, but received limited answers. I searched information online and learned about the theories of Dr. Lawrence Klotz in Sunnybrook in Toronto, Canada, which in 2005 were receiving attention and recognition. My doctor predicted a very uncertain future for me if I didn't go for a treatment. My wife and I decided I should not have a treatment and do further studies. At the age of 61, I was not ready to take the risk of possible side effects, impotence, and urinary incontinence. I also believed that I could postpone treatments. Prostate cancer treatments would advance. I had no idea at that time that my PSA values later turned out to be satisfactory conditions for being able to choose active surveillance treatment. My wife and I decided not to tell anyone outside our closest family about my prostate cancer diagnosis if I was to die. After 2 years, we thought it would be safe to tell, and I started my current journey as a lecturer on prostate cancer in men's clubs and supporting men who were being diagnosed with prostate cancer. The years I was in active surveillance were 14, and I enjoyed full quality of life. 2 years ago, it was found that a part of one biopsy sample taken was Gleason 8, 4 plus 4, and the lesion was close to the surface of the gland. I could have waited and watched the development instead of having a treatment. I thought it was a different case to be treated after 14 years of active surveillance and being 75 years old and being 61 years old. I then undertook radiation therapy which ended in February last year, and androgen deprivation therapy. My PSA is now 0.04. There has been a great progress in prostate cancer treatment during those 14 years, not least in the radiotherapy. It should be noted that the sexual desire disappeared during the treatment and has not yet returned. My wife and I think with gratitude of the 14 years I enjoyed full quality of life. The second question is the importance of second opinion. I think it's most important to get different opinion in diagnosis, not least when decision has to be made that can affect quality of life of the person in question. This also applies in the case of institutes where few samples are taken for analysis and relevant analysts receive limited training in analyzing. I read once the advice that when seeking for a place to be diagnosed, we should choose place where number of samples are taken. It was stated that analysts need to analyze at least 1,000 samples before they are fully qualified to arrive to the correct results. I have chosen to have second opinion by foreign experts. I have visited Dr. Barents at the University of Hospital in Nijmegen in Netherlands for a few times, and in connection with Europa Uomo meeting in Frankfurt 2019, I went for a targeted biopsy with Dr. Vogel at the University Hospital in Frankfurt. The results were different from what I had received in Iceland and changed my decision making. So I recommend second opinion. And the third and last question is how to cope with anxiety during the journey. Personally, I have mostly been free from worries on my prostate cancer journey, except in the beginning, as I reported earlier. However, I know that many prostate cancer men have great anxiety after being diagnosed, and also after choosing active surveillance, and also after undergoing treatment. The fear when being diagnosed with prostate cancer is due to ignorance. To be diagnosed with prostate cancer is not as deadly as many men expect. In fact, if detected early, the life expectancy is over 90%. But it is difficult for men to get to grips with the complex prostate cancer issues under the strain of diagnosis and to evaluate the treatment options they face. Many men want their doctors to decide for them if they should be treated or not. In the decision, so I have pointed out to men that their spouses have to make decisions themselves, and therefore it's important to acquire knowledge about prostate cancer on their own. Urologists cannot make decisions for the individual. They can review the choice of decision-making options, but decision will always be the individual's. I once asked a urologist why he didn't advise men who have low scores and choose active surveillance. And he answered, I cannot. If I do so, a few years later, the evolution of prostate cancer has gotten worse. And then men will ask me, why did you not lead me into treatment? I naturally list active surveillance as one of the options. I have the feeling that doctors in some cases have the tendency to recommend treatment, especially in the intermediate risk Gleason category 7, 3+4, to be on the safe side. Then choose to go for a treatment immediately after being diagnosed become often very regretful. The men are shocked when they are being diagnosed and ask the doctor to remove the cancer immediately. After a few months, when the side effects appear, they have reservations about their decision. Many men in this situation have told me that they should have taken more time to look more closely at the situation and option before making a decision about a treatment. And the big question is how to reduce anxiety, both under active surveillance and after treatment. When I was first diagnosed in 2005, I was very lonely. I didn't know anyone who had not been treated and I could talk to. Doctors strongly encouraged me to go for a treatment. There was little information available in Iceland. I was lucky to come across prostate problem mailing list chat site in the US, where I received information and could ask questions. Many people were incredibly diligent in providing information. The information and support I received from the site proved invaluable to me. There is a plentiful of information about prostate cancer, for example, in English. In Iceland, there is a prostate cancer information to be found about cancer on the Icelandic Cancer Society website and in a compartment called Men's Chamber. We at Frankfurt have our own website where we share information about prostate cancer. Our experience, however, is that most men who are diagnosed or are on active surveillance are not very active in reading this information. Many men do not even know their PSA or Gleason value or what they mean. My long experience in dealing with men who have been diagnosed is that information will be important, but even more important is what I have called nearness. That means close communication with others who are on the same prostate cancer level as themselves. People who have chosen active surveillance need to be in contact with other people who have longer experience of active surveillance. Those who have undergone treatment need to be in contact with people who have more treatment experience. We at Frankfurt are experimenting with a new organizational approach. Our association will be working as an umbrella organization for 3 types of support groups. One is the support group of men who have been diagnosed with prostate cancer, and then another for men who have not undergone treatment, have chosen active surveillance. And we are preparing to establish a support group for spouses. When it comes to educational meetings, the type of groups need to be taken into account. People in the support group who have already gone treatment have limited interest in learning about new methods of treatment, but people in the active surveillance group do. Men who have undergone treatment are interested to know how to improve their quality of life, like sex life, and how to monitor it after being treated. It is regrettable for men who have undergone treatment to hear discussion about active surveillance. This work of ours in Iceland is in progress, and there is not time to tell more details. And at the end, my friend and I took the initiative in 2014 to establish the first independent active surveillance support group in Iceland, and probably elsewhere. After we started the group, the members claimed that they would have liked this support group to have existed when they were diagnosed with prostate cancer and chose active surveillance. It would have relieved and anxiety. The closeness of others at the same prostate cancer stage seems to me to be the key to reducing anxiety and fear with the support of good information. Thank you for the attention. With warm greetings from the volcanic Iceland. Thank you.
Thank you very much, Train. For me, and I think also for the other, your testimonial of active surveillance is a good example, and in a certain sense positive. Now I will bring the other testimonial, which is from Ettore Fumagalli, which has been the president of Europa Uomo Italy for 9 years. Ettore asked me to read his presentation. He could not join us. In this case, this is a different case, and unluckily for him, Ettore did not have the opportunity to choose active surveillance back in 2004. Let's go through his testimonial. Ettore is very active till now in financial investment market. So now of elderly age. Around 8 years he has now. He had a radical prostate cancer operation in 2004 after suffering from a benign prostate swelling for many years. In his case, after a pharmaceutical treatment, when he discovered the PSA around 6, he had 4 biopsies, at that time without anesthesia, so not even very nice. Everything was with negative results until he got the results from the screening, which he asked from a urology in the United States. He wanted to be at the highest possible level of decision, but unluckily the diagnosis was Gleason 3+3, so it was a diagnosis that now is amenable for active surveillance. But at that time, what happened is obviously they decided that it was not able to continue to take part to the pharmaceutical study finasteride. And it was contacted, he went in contact with an important Italian urologist, which suggested him called for an operation without giving him many choices. The pressure was high, the news was really a shock for him, and even if he had let's say, he had a technical study, was also university background. He didn't have the faintest idea what he has to do. He decided, let's say, he was pushed. He said he decided to do the operation, and so I didn't have the good choice. And what happened is that obviously he got some side effects which were not very not expected at all. But during his convalescence, he had a television of the inauguration of Europa Uomo, inauguration of Europa Uomo Association, by an important doctor in Italy, Veronesi. And he decided to join in 2007, participate to the first encounters, and began to understand about the prostate cancer. He became aware that of the problem that he had when he went under the surgeon and the operation. He didn't have the idea, and he saw that in the same time, most men in Italy and didn't want to talk about prostate cancer and did not have the idea, so were obviously going to get side effect with, like, for instance, the most relevant for hetero was a sexual consequence. On the other hand, the urologist at that time and even later tended to appear to the male patient with the surgery instrument in their hands, even before examining the likely patient. So it was really for him a mission, because he was already working in voluntary work, giving blood donation, other activity, and decided to push a lot and to give a lot of attention and create this association, which now we are going on, with the idea of giving information, sensitizing the institution, represent the right of the prostate cancer, supporting friends. It was really for him, he did a fantastic work, because now a lot of patients, like for instance me, were instead in a situation where they could choose active surveillance without going in that direction that for him was not good. In particular, there was the doctors, the multidisciplinary logic. Ettore is quoting an example, which is the different situation that is one of his cousins had after a clinical diagnosis of the same type, Gleason 3+3 in 2010. So this is his cousin, where in 2010 was suggested to start active surveillance, and didn't result, and he had obviously a lot of a better quality of life. During the work that Ettore did in the years, the idea was to especially to push for the multidisciplinary approach, and create more care about instead of using surgical operation without many support. Obviously, this progress were coming also because in Italy we started the program of prostate cancer program from Mr. Baldani, you saw in last conference. The created culture. There was the arrival of the Da Vinci robot. The active surveillance became more known, and so let's say the experience of Ettore was bad for himself, but we have to admit that he did a very fantastic work to support the other people in Italy to have a better quality of life, what we are experiencing. So more or less, this is the experience of Ettore. So, and the idea we had is to show, obviously, what has been done, the different cases between one case of active surveillance and without active surveillance. Ettore is at disposal in any case for questions when you want, and he is giving us providing us compliments to do these actions. This action was also supported by Malcolm Duncan, which was his he was support person and was helping me to create this testimony. Okay, so thank you. I hope that was clear. We will have then questions and answers. Now, let's say we go in the third part where we want to give the speech to Professor Chris Bangma, which is a very important role in Europe as a professor chairman of urology at the urology department of Erasmus Rotterdam. Obviously, I sent to Chris a lot of questions, but he will give us an overview on his best experience. The idea is talk about benefit of active surveillance treatment, which cancers are more amenable for active surveillance, what is happening with early detection, early diagnosis all over Europe, and the benefit that the early diagnosis and active surveillance are bringing to the world, to the men in Europe, and will probably bring more in the future. I asked him also to give an idea of the study, the prior study, which is done in Erasmus. So, Chris, how are you today? I hope you are fine.
Thank you very much, Cosimo. I'm perfectly fine, and I hope that you can hear me well.
Yes, yes.
And I'm very thankful that you give me the audience today. And let's talk about this active surveillance. I'm very much impressed about the testimonials because they reflect, I think, the lives of hundreds of thousands of men in Europe struggling with prostate cancer and struggling with making decisions on their own, with others, with their physicians. And I can only say, just like Svein was telling us, although the suggestion of his background with a volcano and being cool on Iceland, it hides a little bit that anxiety might play a big role in the daily life of a prostate cancer patient. So we can be sturdy about it, but please communicate with each other the best you can. Now, we can probably talk for many hours about active surveillance and just see my presentation as something that is a reach out for questions to pose within this setting or around it. But I'm very happy that Europa Uomo for many, many, many years already facilitated this pan-European discussion between patients and physicians in this field. Now, what I want to highlight is, at least by these two testimonials, that there is some kind of a tension between the one and the other. The early detection of prostate cancer, being in time for a curative treatment, and then, on the other hand, being diagnosed with so-called harmless or irrelevant cancer and suffering from that presence all your life, suffering from the anxiety that it might change into something realistic that needs to be treated. These two items are fighting each other, and I will show you a little bit why. Angela is helping us with the slides. As usual, the women push us forward. So Angela, please do, and give us the next slide.
Oops.
And I hope Angela is still there.
Angela oops.
Can you see the slides?
Yes, yes.
Yes, we can see the slide, but we'd like you to proceed them because I'm limited by my university making use of Zoom. So I'm asking you to go to the next slide. Anyway, while busy looking for the correct button, I can only start with telling you the story of screening and prostate cancer, because in the 90s we started with PSA. The PSA was an easy test. It was a blood test, and everybody could get their PSA from the GP or from any physician. It was cheap. So from that moment onwards, there started some kind of an awareness that you could find prostate cancer by means of PSA triggering biopsies in the general population. And that's what people did. So more or less, PSA started the anxiety. And so we introduced screening, and there was an enormous screening activity amongst Europe, a large randomized study, and that showed in the end that screening could reduce mortality. So the mortality due to prostate cancer could be reduced by the screening. Unfortunately, it also introduced an enormous amount of recognition, diagnosis of these harmless and slow-growing tumors that Svein was telling us about. And that's what we call overdiagnosis. Actually, you're being diagnosed with a cancer. However, this cancer is harmless for you because it never gives you symptoms, and therefore you live with the anxiety because it has to be checked again and again and again. So what did we do in the early 20s? So Professor Klotz and others, and also in Europe, people started with programs taking care of active surveillance, not doing anything, not treating immediately, like Cosimo told us about the Ettore story, but keeping an eye on it and looking whether things would change, whether the risk would change. And therefore, active surveillance was invented, and it had to be done in protocols because we did not know the behavior of all these tumors that were diagnosed but were Gleason 6. They did not seem to be aggressive. So this was overdiagnosis, but this overdiagnosis also introduced overtreatment, and that is a little bit the Ettore story. There was a Gleason 6 tumor, and it was operated upon with side effects for many, many, many years. The same was for radiotherapy, and these side effects, of course, were unnecessary if you looked at the biology of the tumor, because you could have lived a very long time and maybe forever without an operation. So the side effects of all of this screening and PSA were anxiety. There were functional disorders like erectile dysfunction and incontinence. And there were, of course, also societal costs. And therefore, these were the side effects of overtreatment. Now, the story goes on, although the slides will be taken later, but everybody is familiar with the fact that there are multiple, let's say, aggressiveness levels of these cancers. And some of them, they act like slow turtles, and others act like birds. You cannot catch them. They are very aggressive. And whatever you do, even if you try to screen them early, they will result in metastatic disease, and you will die of it. And then there is a large part of tumors in between that grow. They need to be treated because they will become symptomatic before the end of your life. But unfortunately, you will suffer the side effects of that. We are talking about the turtles, the very slow and non-progressive cancers in prostate cancer. And when you have such a cancer, what happens? Because you're starting to bother what to do. And here we see the slides, and we go to the next slide. Angela, thank you very much. It goes very well with the slides. And so there are 4 questions for patients in the next slide, and that is, when would it start bothering me? What is the point? I'm anxious from visit to the physician. What is happening? What is my life expectancy? Is my cancer going to survive me, or am I going to survive my cancer? Who is the more aggressive one? And what will be, in case of treatment, the reduction of my quality of life, as we heard from the Ettore story? And maybe more precise, what happens if this is being diagnosed because of an early diagnosis for whatever reasons? If I'm 50 years old, what can I predict? Can I predict it till the end of my life? That would be something if we could predict the end of life and then also know what the biology of the tumor would be. Well, these things are suffering for patients. And then here you see, of course, the summary of all the side effects, but what you can appreciate, whether you get a treatment, radical prostatectomy, or whether you get radiotherapy, a large amount of patients, over 10%, maybe up to 30%, will suffer from severe side effects that will affect their quality of life. And of course, that is a psychological mechanism. After 2 years that you have been incontinent, you learn to live with your diapers, and you get in peace with your diapers. And you say, my quality of life is good, but it was unnecessary, unfortunately. Next slide, please. Now, Europa Uomo made an inventarization, a questionnaire for all of these side effects. We're very grateful that Europa Uomo took the activity, asking so many patients, how do you suffer? And so it shows real life. People suffer from incontinence. You see the graph on the top left, and you see the least incontinence sufferance is when you follow active surveillance, of course, because that is the situation in which nothing alters. And the worst is when you do a radical prostatectomy, because then early on, maybe 30–35% of men are suffering some form of incontinence, which in case of harmless tumors would be unnecessary. Next slide, please. So here we have it, the benefit of early detection. Large study being done, it can give less mortality. Moreover, it can reduce the number of patients with metastasis, painful metastasis, and a lot of medication, but it has a side effect. It can be beneficial for the patient that has been treated with success and cured without the side effects, but it will cost for the individual with a low-risk cancer being treated or being diagnosed because of screening, and of course there are costs around it. Next slide. So what I want to say, active surveillance is only, let's say, an invention in order to compensate for the screening efforts. So when you decide to get screening for whatever reason, because it is in your family, or that you're just anxious or being pressed by your surroundings to go for screening, just realize that you can end up in a situation in which you have to act in active surveillance. Now, active surveillance is safe. We now know it, and we have the experience for over 10–15 years, how to manage active surveillance. And I will show you the outcome of results after 15 years. But these programs, and especially in Europe, everywhere accepted programs like PRIUS, gives you some support in how to do it together with your physician, because it gives a protocol of regular checks by PSA and by imaging that has been introduced during the last couple of years. It gives quality control because all the physicians and technicians and doctors and whatever can look over our shoulders at the program, and they can check it. Therefore, there are many people who check the programs. And over the years, we have improved. Next slide, please. So this PRIUS program is on the internet, and it can show you the support. For example, you see a timetable over here. It shows you when to check. When to go for a PSA or for a biopsy or for imaging. And it also gives you an overview, for example, in the left-hand side of the individual PSA curves. Now, PSA is a support. It does not always give you a realistic situation of the biology of the tumor, but it supports you in order to make the decision to take, for example, a biopsy or to take an image, an MRI, in order to check your tumor. Next slide, please. And this is an international program accepted everywhere around the world. It has support in very many European languages. It gives you the exact protocol to read by yourself, by your spouses, by your physicians. It gives you contact addresses. It has passed the quality control everywhere. In every hospital you are being offered this program, but you can follow it also on the internet. Next slide, please. And here you see the acceptance over now more than 12,000 in 2021 patients in Europe and in Canada and in Australia are supporting with their data the research, about prostate cancer active surveillance. And with all these experiences, we can improve. And we did over the last few years by introducing, for example, MRI or perineal biopsies or new Gleason scores or new markers or the incorporation of genetic markers by BRCA2, etc., etc. Next slide, please. Now, it's not the it's not the single protocol around the world. There's many institutes around the world who have slightly different protocols, but because we are fully together in one consortium that is called the Movember Global Action Plan, which I'm the coordinator of, we have merged all this information from around the world in over 25,000 pieces of information about patients. So we are growing together and merging, but you have to realize that an active surveillance program in Japan is different from that in Europe, is different from that in the United States. We see the serum and urine markers that have been invented over time as indicators. So they're not the proof of cancer, of progression. They are the traffic light for especially looking right and looking to the left in order to proceed. The imaging has not been fully validated yet. There's a lot of efforts in order to recognize and to biopsy correctly. But at this moment, we are looking for the follow-up. Can imaging replace, for example, a biopsy? But we do not know yet. So anybody who claims that imaging can replace a biopsy has discussed that with you as a patient very intensively, because there is not scientific proof yet. But we're going to have it because we are collaborating with so many patients, with so many institutes. And genomic markers, as we talk, are being tested. And we have founded a consortium from the United States and from Australia, together with Prius, in order to test new markers that will support whether your information, whether your tumor is aggressive, yes or no. So all of these are risk factors that contribute to your risk classification. While you are on active surveillance, you have to redo and reassess your risk, just like a fire insurance of your house. You have to invest into a risk assessment every year or every 2 years or every 3 years in order to see whether things have changed. Next slide, please. And what we know is that people are doing better if they are on a protocol, because they are being checked more regularly and there are many people looking at you. So you see here a curve in green that people that are on a protocol remain more often on active surveillance because they feel supported. They have less anxiety and they know that when the protocol shows any change in progression, then they have to act and not before that. The other thing that we've learned, for example, that the size of your prostate is extremely important. And you can understand that more PSA means a bigger prostate. It does not mean always more cancer. So therefore, in all of the protocols nowadays, the size of your prostate is important to correct the level of the PSA as an indicator of your risk. And so we learn. Next slide, please. And here you see the long-term results. And the long-term results are like in Canada, like in the United States. It shows you as the main message that yes, there is a small chance that while on active surveillance, we miss things. The MRI doesn't see everything. The biology of the tumor is not being recognized because we do not know the genetic landscape of every tumor as yet. So the risk is very low that in the end, you might be diagnosed too late with progression, but this risk is very low. 98% of men are safe on active surveillance. And that is over the time period of 15 years. So when you're 50, we cannot predict how you will be when you're 80. We can look forward 10, 15 years, but that is it. Yeah, that is also reasonable. But in 10, 50 years, we know far more and many things. And so we might be better being able to handle your active surveillance cancer. And then the other graph shows the reasons why people shift to curative treatment. And all of the colors can be explained, but it was also about anxiety. And this graph shows that the minority of men on a protocol, well balanced with discussions with their physician, is shifting because of anxiety. So it supports not only communication with other people and patient supports, but also these kinds of protocols. Next slide, please. So anxiety. Anxiety is something horrible, and you can live with it, but it can be sometimes a big mistake. And it means that anxiety is very much a threat to our lives and to the quality of our lives. Next slide. We try with the professionals, together with Europa Uomo and the European Organization for Urology, the EAU, to provide you with guidelines. Guidelines are the results of methodological studies, scientific studies on the behavior of cancer. So these are the evidences you can rely upon when looking at active surveillance. And actually what this slide shows you is more or less a support because you can read it and you can see what is certain and what has a strong evidence and what has weak evidence, and we still have to learn from. But anyway, it gives you the impression that many, many people are supporting this research and therefore the outcome of active surveillance and giving you the reliability of the profession to support you. Next slide. And we know, of course, that biopsies and repeated biopsies are horrible. This slide shows you over time that although people on the protocol should have a biopsy, the following of PSA is quite good. That's the dark brown bar over, let's say, in time, in 5 years or 10 years time, more than 80%. But there is some kind of a reluctance of repeating the biopsies. Many people feel that an annual biopsy is awful. A 3-year biopsy, like in Prius, is followed well, as you can see here in the bar with 60%. But over longer term, the enthusiasm to repeat the biopsy is declining. And of course, that is a natural reaction of a man who feels that after 10 years and nothing has been found so far, he can relax a little bit and say, okay, my tumor is not that bad. So please, let's skip the biopsy. We as doctors have to rely on the scientific methods, and therefore the protocol prescribes us that we have to do a biopsy, but of course, we would like to change that to, for example, imaging with MRI. So we're busy with that, and we understand that the protocol is something different than the patient feelings, and that is exactly what you have to discuss with your doctor in the outpatient clinical room. Next slide, please. We'll come to the end of this presentation. We have checks and controls. We have risk evaluators. We have imaging. We have now improved towards transperineal biopsies. That means less antibiotics, better performance of the biopsies, and therefore also predominantly far less infections. So please ask for transperineal biopsies at your doctor's place. And we are getting into risk evaluation that is personalized. Next slide. The next slide is probably, that shows you the summary of it. Active surveillance can avoid side effects. It's delaying treatments or even abolishing it. It can be well selected and well monitored, but the side effect is anxiety, regular checks, and missed curable cancers in a very tiny amount of patients. Next slide. And this is what we are working at in Europe at this moment. That is a personal risk assessment. As you can understand, the MRI in the one person is not the same as in the other person. And the PSA decline or increase is not the same. We are not the same people. Like we're sitting here, we all have our individual stories. These individual stories are full of individual risk elements. And we would like to say to the one patient, okay, you need a biopsy next year, but to the other patient, you can wait 5 years with your biopsy. And that's exactly what we want to accomplish with a personalized risk strategy. Next slide. So, how to be on active surveillance? Some general lifestyle things. Keep moving, keep active. It's the best you can do. Eat well, not too much meat, you know. More fish, more vegetarian, more fresh foods. You can handle your disease. You can support handling your disease by others by doing these things. Message is stay on a schedule, be in a good communication also with your physician, and relax. It's safe, it's good, it's being checked, it's being controlled. So next slide shows you the end of my presentation. It was the show from Rotterdam, but we are, as much as anybody else, collaborating with all over Europe, and very thankful of Europa Uomo supporting our work, the work that is dedicated to you as patients on active surveillance. Thank you very much, Cosimo.
Thank you very much, Chris. I think you gave us very important elements and gave us a very clear idea of all the activities that are done. Just before starting with the possible question answers, I want just to conclude a few words about what the associations, our association could do. And the most important thing is that, I say, a lot of important things have been done and progress now are clearly evident from what you see from this testimony of 2004, when everything was a little confused. Now we have bias, we have strategies, we have active surveillance, we have activities. And but obviously, as usual, a lot of things still have to do, because the activity in the European countries is different. There is a big variation between European countries and within the countries. We think we are trying to work on three sides as Europa Uomo in the central branch, let's say, and in the local association. The important thing, I think, is to have a good communication, to exchange communication, like we will do in the next General Assembly on 19th of June. We are working on awareness, and that is important, and we are speaking in general, locally and centrally with politicians to raise the awareness. We are working on actions before diagnosis, because with for instance, the European Association of Urology, we are campaigning for a screening program, as Chris was saying, with all the guidelines that need to be considered for prostate cancer, which are not the same as other type of cancers. We are cooperating with the European Commission, Parliament, with the early detection. And after diagnosis, we are trying to work both centrally and locally in order to be very important, to be effective, and to be updated with latest activities, with latest developments, including the active surveillance strategy, and also with a lot of actions with patients which can have anxiety from active surveillance or also the other treatments. Which are the objective? The objective is clear. We and also, as was shown by our survey of Europa Uomo quality of life, we want to have to give the people the best quality of life possible, consistent with their status. Everyone is different in case of prostate cancer, but the idea is to work on this. So a lot of work may be done, and a lot of work may be done centrally, like we are doing with the survey on quality of life, which has been the first one made by patients. So we are giving to the European community, to the local community, medical politicians, the importance of something that is coming from patients, to really quality of life appreciation. Every country is different, so I think it's more important to communicate than always, than never. So having said that, I don't want to go on and explain things. I want to give start to question and answer. There is an answer from Peter Zuppa from Sweden, which he could not be here today, so he asked me to present this question. So he was saying, what is the family role in active surveillance, and if there is any prostate cancer screening best practice which could be adopted in the European states? Obviously, these are not easy questions. We can just give an overview. But maybe, Chris, you can give your personal view on this.
Yeah, well, these are important questions, of course. Thank you very much. I think that we have to realize that there is not one pan-European view on screening, because the screening results are also different amongst European countries. We do see that the incidence and also the incidence of relevant cancers is higher in the Scandinavian countries compared, for example, to Italy. And we see, so the southern European countries with more sun, but also with a different diet, do grow less relevant cancers than in the north. We do not know exactly biologic mechanism, but it seems to be an epidemiological truth. And therefore, screening or population-based screening, the activity around it in the Scandinavian countries is much higher compared to, for example, the southern European countries. The family support or the family act. Now, I do not know exactly, Cosimo, what the question is, but it can be twofold. Of course, the support of the family is of pivotal importance. And I think that Swain's history about keeping the information for 2 years secret is exactly as most men do. That we experience it to be harmful to give this kind of awful information to others around us. But at the same time, we are shooting ourselves in the foot, because we also see that talking about this and communication and support, family support, is pivotal in order to keep on a protocol or to keep fighting your prostate cancer. It is best being done by team and not by yourself alone. Yeah. The other aspect might be the genetic elements. And we know by now, since 1, 2, 3 years, that the breast cancer gene, when it runs in your family, that it might increase your risk, but it is very tiny. It's called the breast cancer gene, but unfortunately, it also gives a little bit more risk of relevant cancers in the prostate. But once again, this is, as we speak, not of pushing importance. But sometimes it is the argument for people to say, oh, I want to be screened. But please keep realizing that the absolute risk of this is tiny.
Okay, thank you very much. I don't know if Anya, did you get other questions?
Yes, Cosimo, I have 2, one in the chat and one, Steve wants to ask a question. Steve, are you here?
That's a very good question. Am I here? to you all, I appreciate your humanity and also your sense of humor. I'm in the USA. Doc, Chris, if I may address you as Chris, could you take a moment and talk about those with BHP and the issue of density? I'm just surprised. I've been about 8 years in this walk with AS. I'm really surprised that in any social group, support group in general, and even during the lectures by the almighty researchers, etc., that this issue of a man's knowledge of his density and how that correlates with all the other tests, researches you've done. If BHP is a big issue for some, is there something that we should be doing that helps you on your cause, your research, that helps us as a group of men on this whole issue of BHP and knowledge of density?
Yeah, well, I think just like we were given as patients, as men, the awareness of PSA, we have to give back to our physicians the awareness of the PSA density. Because by now, by the scientists and the academics, it's obviously clear that this density is also, by logical arguments, very important to assess the risk of the prostate being benign or harboring a relevant cancer. So if you want to do something for us, Steve, just ask your GP or your physician next time, what's the size of my prostate?
Okay, thank you. Anya, the other questions are by
Professor
chat.
Bangma, do you still have time? I have one question in the chat.
Yeah, sure. I thought it was a question about mushrooms.
Yes, you saw it.
It remembers me that it is eating time, actually. It's dinner time. Anyway, but it's good to discuss because, yes, on the commercial food market, many food additives and ingredients have been offered. And we cannot exclude whether they are very good or very wrong, because it's so difficult to prove if you eat for the rest of your life mushrooms, how this going to affect the biological behavior of your tumor. Still, we know from epidemiological studies that men in Japan eating vegetarian food that move to the United States and starting to eat burgers get prostate cancer. So we know from epidemiological evidence that food is of influence. And we can only do the best thing in our lifestyles. We know what is good and what is bad. And I'm not talking about a glass of red wine or white wine or the difference between that. Please do enjoy life. That's good. But limit, let's say, the excesses of dairy products, limit the excesses of red meat, things like that. And if the mushrooms will do, and it keeps you and your family on a good diet, well, take your mushrooms. It's I'm a strong believer in the positive thinking and the support of positive thinking on the behavior of yourself and your cancers.
Good. So I think there are no more questions from what I see.
No.
There's a question for food.
It's the time for food. Okay, it's lifestyle. Okay, thank you very much, Chris, and thank you for everyone. I think it was useful for all of us, and it will help us to go on and do things that are useful for us and for other people in the future. Thank you very much. Bye.
Thank you very much.
Thank you. Bye.
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 Bye. Bye.